Hello, everyone, and welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Therapeutics. My name is Rain Bennett. I am your host, and I'm a filmmaker that's been working with CCF for a decade now, folks, since 2011. And we've created videos and documentaries and now live video series, all with the same mission in mind, and that is to help spread awareness and education about neuroendocrine tumors. So if you are a friend of the show, a regular, you probably know what to do next, which is to let us know where you are signing on from in the world. I love to see how far these programs reach. So go ahead and do that. And I'd like to say, if you are a regular to the show and you are used to seeing me every week, you might have noticed that I was gone last week. I just wanted to update you all a little bit about that. I don't want to go into too much detail, but my family suffered a pretty tragic loss last week. Some of you all have reached out to me. I appreciate that. I received your messages. Again, I don't want to go into detail today because we have work to do. But if you would like to learn more, you can always find me on my personal accounts. My name is Rain Bennett. I'm pretty Googleable. There's not a lot of Rain Bennetts out there in the world. Thanks, Mom. So just know that I felt your presence, and now more than ever, I have a clear understanding of some of the topics that we talk about on this show, specifically how important it is to preserve and maintain and fight for that quality of life. We talk about that a lot versus quantity of life, and every net patient really seeks to have that high quality of life while they navigate this. And I just wanted to send my love to you all. And with that being said, this show is still very important, and we will keep going forward. Before we keep going forward, we always want to thank our presenting sponsor, Therapeutics, because we couldn't do this show without them. But we have this disclaimer from them, and that is that the opinions expressed by the guest presenters, as well as the questions asked by the audience, that you all at home, haven't been created or suggested by the sponsors of Luncheon with the Experts, and CCF doesn't endorse or promote any of the views, opinions, information provided in the presentation. Audience members should not rely solely on the opinions or information expressed by the guest and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. And that last line is really the crux and the takeaway. We are going to give you some great advice and answers to your questions, but we don't know your specific case. So take that advice and those answers to your questions back to your home team, which does, and make the best plan and path for you moving forward. So today, I am very excited to welcome our guest, Dr. Emil Liu. Dr. Liu, how are you, sir?
I'm doing well. Thank you so much for having me, and condolences to you and your family.
I appreciate that very much. For those that aren't familiar with you, where you work, what you do, tell us a little bit about yourself and the role that you fill in the neuroendocrine tumor community.
Absolutely. I'm really honored to be here today. Thank you so much to you and CCF and everybody out there. I'm intrigued to find out where everyone is from. I heard it's a quite global reach, so kudos on that during these challenging times. So my name is Emil Liu. I'm a medical oncologist, associate professor at the University of Minnesota in the Twin Cities, and specifically it's located in Minneapolis. I've been here over 10 years. I trained at Memorial Sloan Kettering Cancer Center, where that was my first exposure to neuroendocrine cancers and neuroendocrine tumors, under the leadership of some world experts. And so as I learned from them over time and developed my own practice, predominantly in GI cancers, I do also have a background in brain tumors and neuro-oncology. And I like to believe that has informed some of my understanding of neuroendocrine and interest in neuroendocrine tumors. So I treat a lot of patients with this type of cancer, or a series of cancers.
Gotcha. What percentage would you say of your patients are net patients?
It's growing a lot. Certainly, in the last few years, I think it's maybe grown to as much as a quarter. Some days I go to clinic and it's stacked with neuroendocrine tumor follow-ups or new patients seeking opinion and advice. So definitely, for something that's I like to say something that's relatively uncommon compared to other types of cancers that are more in the news, it's not uncommon to me because I see so much of it, and a lot of those are nets, very specifically.
Gotcha. And speaking to your point about the people and where we are, we got a lot all over the states is always covered, in Canada as well. But I see some representation from England already. So already some people who are getting closer to nighttime. Hi, Rebecca. Still joining in. That's what I love to see, Dr. Liu, is we will have people, as I told you when we first chatted, in Australia and India and all these countries watching live. And then by tomorrow, people have, thousands of people have seen it. So folks, here's the deal. If you aren't a friend of the show and a regular, as we call them, go ahead and send in your questions. We're going to do our best to get to all of them. However, We typically get a lot, so we don't always get to them. So follow up with CCF. You can send them a message or an email at carcinoid.org and try to, follow up with them if you have questions that you didn't get answered, or join us next week. We're here every week. Also, you can replay this video. So if you arrive late, if you missed a note that you were trying to write down, this is going to live here on the page, so you can always refer back to it. And starting Monday, we republish it to YouTube for those that don't have Facebook. If there's anyone that that should be here right now, because really the value is this interactive session and this community that we've cultivated here in the audience of Luncheon with the Experts, go ahead and tag them now and let them know that the show's going on, because they can watch it later, of course, but being able to get that question, this virtual interactive session with an expert, I think is really, really important for them. And then another thing that I mention every week, you all do very well at this, and it helps me do my job, is to, if you see a question in the sidebar that you also have, or you're interested in the answer to, you can if you hover right below the comment, you can see a like button and a reply button, and you can like that or love it or any of the emojis that Facebook gives you the option to use. They all work the same way for me, which is to upvote it essentially, or effectively. It lets me know there's a demand for that question. So when I'm going through 100 questions in an hour, if 7 or 8 people have this one question, I'm going to make sure to get it across to Dr. Lou. Okay. And another thing, if you comment back later referring to something you mentioned before, continue to give context, because again, there's a lot of questions. So if I see later on the show someone say, I meant well differentiated, I may have not remember, exactly what the question was for. So try to make it a complete comment each time. That will help me very much. And my job is to help you. So essentially it helps you as well. So Dr. Lou, you mentioned something when I was asking how many are your percentage of net patients, and you mentioned that it is growing. Mm-hmm. And I don't think that this is anything, a strange fact to the people in the audience today. It seems that the number of net patients being diagnosed is in fact growing. Now, my question is, why is that? Is that an increased amount of cases, or is that an increased ability to diagnose this?
Yeah. Yes, all the above. Right. So kind of delving into that, I will say from a diagnosis standpoint, so it's a very challenging set of tumors. And so I'm saying set, I'm going out of way to say series and sets, because neuroendocrine cancers, neuroendocrine tumors, we're learning so much more about the biology, about the different subtypes. And so as we see the subtypes in a relatively uncommon cancer, and it's definitely under that banner that the National Institutes of Health in the US and National Cancer Institute, which is under the NIH, will call rare tumors. And I think neuroendocrine tumors as a class overall can be classified that way. And then you get all kinds of different, not just in terms of the what we call the anatomic sites of origin. Where did cancer start? Is it a neuroendocrine tumor of the appendix? Is it from the rectum? Is it from the other parts of the colon or small intestine, or from the lung? And then on top of that, under the microscope, or key characteristics of the molecular oncology of it, make smaller and smaller subsets, overall make it rare. And I think that's where specialty centers of excellence really come into play. So it's not just me as a medical oncologist trying to take that information and devise treatment plans, but it all starts at making the right diagnosis. And I think the field overall, and that includes our fellow physicians who are pathologists, who are the experts looking under the microscope, have gained expertise, and places as centers of excellence that see this a lot, making sure to make the right diagnosis. So it hasn't been too few and far between for us to find out that a cancer that was initially diagnosed, for example, as a colorectal carcinoma, which is 150,000 plus cases in the US each year, but then the review of the pathology changes it to say, no, this is in fact a neuroendocrine tumor, which is the strategy for treating those tumors is completely different. So I think part of it might be a diagnostic bias where we're getting more sophisticated of it, but why there might be also more cases overall beyond that is really a major mystery, and a lot of research needs to unravel that.
What other challenges does that growing number create for you?
So I find it's kind of an intriguing cancer. So it's, I kind of look at it as a diagnostic dilemma and challenge that, that I take on, because I see a lot of these patients. I specialize in this and also see more. It's not just from the diagnostic end, but that's important. And how do you determine the sequence of treatments? Now we have treatments that 5 to 10 years ago in the US and beyond weren't available, and also internationally, but with drug trials showing that there are more and more treatment options, whether it be oral drugs or more in the space of targeted therapy, some chemotherapies proven to work, and then nuclear medicine therapies like PRRT that has really come to the forefront in the last few years. That's just one example. So in the great state of Minnesota, only 2 centers have it, and our center, the University of Minnesota, is one of them. And that has certainly led to an uptick of referrals, specifically to me and my colleagues at our center, because we have this as a treatment option, and we can provide that for patients who've tried a different type of therapy that's appropriate for their version of neuroendocrine tumors, but they need this treatment, and we have it. And so the patients might come, they'll undergo the treatment, and then we'll pass the baton back to their local oncologist. Some patients come from 10 minutes away, some come from 10 hours away or states away, just because of the broad view of the upper Midwest. Many centers may have it, but we can offer it. And so I think that's definitely a component in me seeing more of these cases over the year as well.
Absolutely. Folks, go ahead and start sending in your questions. First of all, I see Dr. Robert Ramirez chiming in. He tends to, I always say, hide out in the rafters of the show, like the Phantom of the Opera watching, and is happy to see Dr. Liu. Look forward to learning. That's another thing I got to say about this community. It's not just the patients that are such a tight-knit community. I find that the doctors are as well. And even if they don't necessarily work together, they kind of work together, even from across the country and across the world. And I think that's something that's really special about this disease. I definitely see it within the patient community, but I haven't called that out as much, that it also exists within the experts and the specialists and the medical community too. And
absolutely.
Dr. Ramirez, Dr. Chowan, a lot of people watch the show. They've been on the show, but it means a lot to me, and I know the foundation that they're here all the time.
Special thank you, Dr. Ramirez, and others watching.
Absolutely. And Dr. Ramirez, I'm sorry I missed you when I was in Nashville a few weeks ago. We'll try it again next time. Okay, so we got some questions coming in. Dr. Liu will go ahead and field some of them, and we'll have a chat. We've got about 50 minutes. Let's get into it. Jesse says, I know the 5E list, and I want to discuss what that is, the 5E list and the food list. Do we need to watch out for tropicals? Will products like lotions with coconut oil cause carcinoid symptoms? So first, let's establish that what is the 5E list that Jesse is referring to, and then we can field that question.
Yeah, I think I've not heard 5 E's before, so maybe it's something that I have different parlance for. Maybe she can clarify.
I've heard it, but I forget what they stand for. But it is in the nutrition or dietary realm. And I'll jump in really quickly, Dr. Liu, there, and say, Jesse, I mentioned at the top of the program, I've done videos for 10 years with CCF, and including this show for over a year now. So we have several videos on nutrition from dietitians and nutritionists. So I would definitely encourage you, and this goes for everybody. We've got videos about almost every topic in this disease, to refer back to some of these that go a little more deeply into these certain subtopics, if you will. So I don't know how you feel about the rest of the question, Dr. Liu, but do we need to watch out for tropicals? Will products like lotions with coconut oil cause carcinoid symptoms?
Interesting. So maybe we'll take a step back and just, as I know you had mentioned, Rain, that a wide breadth of audience and people coming from different angles, including patients who and caregivers who may be new to the carcinoid tumor space and neuroendocrine tumor space. So neuroendocrine tumors, not all of them produce a syndrome that is characterized by production of hormones. So it's really a really unique class of cancer, because not a lot of cancers form things that go into the blood and cause symptoms that often lead to the first symptoms that lead to diagnosis of the cancer. Less than 1% of all cancers, or certainly all solid tumor types, have something called a paraneoplastic syndrome. And that's something of interest to me. It's yet another rare thing where antibodies will spill out, and maybe they'll cause seizures, and maybe they'll cause neurologic problems. Neuroendocrine tumors, about 40 to 60% are in that space called functioning tumors. So they make these different hormones, and carcinoid is definitely at or near the top of the list, and the type of cluster of symptoms that happen, and also the type of hormone that comes out. There are standard tests that I think the listeners are probably very, very well versed in, and probably better than me. But what's interesting is that these hormones can cause things like severe flushing of the face, redness in the face, tons of diarrhea, loose watery stools that are not controlled by like over-the-counter things like Imodium, and maybe even some heart palpitations, effects on heart valves. But what's interesting also is that sometimes it can be stimulated by not just activity, but also by food. And so I think I'm going to take a guess, and please correct me if I'm wrong, that things that we can control that would stimulate the worsening of the carcinoid syndrome, 5Es might be one reference to. I might think of things like tryptophan and just kind of the biochemistry of it. But things that like foods that might stimulate this. There are some foods that are thought to stimulate it, whether it's things like caffeine, or I think of tryptophan. People think at the time of Thanksgiving, the T word comes out and people think, wow, if I eat a lot of turkey, tryptophan is stimulant. And so In non-carcinoid type of tumor situations, there can be other types of things that are more rheumatologic and other things that are internal medicine like that can stimulate similar symptoms. But in carcinoid tumor, patients with carcinoid tumors that have the hormone produced and it's causing those flushing symptoms, certainly there are things that can elicit that and exacerbate it. Whether if the tropical question very specifically refers to like you're on the beach in Turks and Caicos or in Jamaica and you're putting on tropical oil that have certain stimulants. I'd heard that before in terms of the question. I don't know whether that's been proven. It's really interesting, but it's the idea of ingesting something, maybe like dark chocolate or caffeine stimulants that might exacerbate carcinoid syndrome versus applying on your skin that it might be absorbed. In general, my understanding of things that are absorbed is certainly not 100% of anything you put on your skin gets absorbed to the bloodstream to have enough of it in your bloodstream that would cause an effect. But it's a fascinating question.
Got you. And our COO and really the engine behind all of this, Grace Goldstein, who usually will add links in the comment section, folks. If Dr. Liu refers to articles or medications or any sort of resources, she'll add. And she chimed in with an article about the 5 E's, which do relate to carcinoid syndrome. That's ethanol or alcohol, exercise, epinephrine, eating. And there's exercise again, but those sorts of things. So I think that that's still relevant. And that's a good point, folks. For me, I mean, I've worked with the disease for a long time, but I'm certainly not an expert. So the better clarification in your comments, the easier it is for me to field those. But I think that we got it. And Jesse, if you have follow-up questions, please ask that. Moving on. Thank you for your question, though, Jesse. From Nancy, I had surgery 5 months ago to remove my primary, my small intestine, appendix, and multiple sites in my liver. My surgery was 500 miles from where I live. And the PA medical board recently determined that MDs can no longer do video conferences with out-of-state patients. And I haven't heard that. Now I have to fly there for follow-up appointments, obviously making it more difficult. Making it more difficult is the medical oncologist has clinic only on Mondays and the surgeon only on Thursdays. I do understand that difficulty. The question is, Nancy says, if I am having no complications from the surgery, why do I need to continue to see him? Which is now because she has to travel so much for that.
Sure. Yeah, no, it's a great question about the logistics of clinical care oncology and NETs. And also just the idea that during the pandemic, we took a deep dive, and I'll say not just me or the University of Minnesota, it's the healthcare system. It took a deep dive into something that had been kind of talked about for years, but suddenly we were forced to implement it, and it's here to stay. But the concept of virtual visits. And so initially, before restrictions went into place, it was almost I would say a free-for-all, but I say that in a positive way. It opened up the doors for patients, especially with relatively uncommon cancers, to seek out experts and to have FaceTime, literally, small f, not the Apple version necessarily, but an opportunity to meet virtual experts without having the financial toxicity of having to travel these long places. Obviously, if you have a surgery someplace, you physically have to go, but some of the follow-up, I'll say, whether it's surgery for a small bowel neuroendocrine tumor or a colon tumor or a lung cancer, it is standard to follow up with a surgeon. I think it's always about safety practice. So a good surgeon, they're the centerpiece of what the service they're performing is the actual surgery, but everything leading up to that, and also the post-operative care is really crucial. Some of the risks of surgery just in general can be post-operative infection, wound, or bleeding. And I think it's just good care that the surgeon wants to look out. And I think a lot of that cannot be accomplished by virtual visits. From the more logistical nationwide landscape, we're here and no different than that, in that I also had patients taking advantage of the opportunity to meet with me virtually. And then in a state of emergency, we were granted, for example, I was granted, although I do not practice in the state of Wisconsin, an emergency medical license for the state of Wisconsin. So patients from Wisconsin who normally might have to come 3 or 4 hours or maybe more to see me enjoyed to be able to have a virtual visit with me from the comfort of their home. We saw each other by video for initial consultation or some follow-ups that were appropriate. And a lot of those restrictions went back into place as the pandemic progressed. So patients from North Dakota or other parts of the country no longer do that because I don't have a license in those. I suspect that's what's happening here. If PA refers to Pennsylvania, there could be there are excellent net experts there as well. But if you have to fly out of state, as it sounds like here, if you had surgery there, that would be the standard. I think it's predicated on safety. I'll say the logistics of medicine are not always patient-centric and patient-friendly. So if an oncologist is there on a Monday and a surgeon on the Thursday, that definitely can happen. And it's it's something that presents a challenge if someone's coming out of town and they say, well, what are you gonna do Tuesday, Wednesday? Just kind of waiting around, waiting for the next visit.
Yeah, absolutely. Thanks for your question, folks. If you just joined us or joined us a little bit late, this is Luncheon with the Experts, a Carcinoid Cancer Foundation program. And our guest today is Dr. Emil Liu. Great questions so far. And just to recap on the 5 E's, the 5th one is actually emotions. So exercise, emotions, epinephrine, ethanol or alcohol, and eating. So I learned something new today. I had heard that referred to. I just couldn't recall at the moment what those were. So thanks, everybody.
I appreciate the clarification as well, because each of them is like in the domain of what I was saying, but I'm like, oh, there's an acronym for it. Not the actual acronym, but I think just briefly, just to make sure I answered Jess's question fully, the epinephrine, so fight or flight mechanism, so times of stress, you know, and eating is maybe not related to stress per se, but the other items are, and I've had patients who are runners, or they have stressful jobs. They do physically demanding jobs. And it's almost like it comes out of a textbook and saying, I was exerting myself and it's 99 degrees heat and I was working, you know, on my patio and I was doing hard labor. I have a stressful job and I'm a teacher. And in summertime, when I'm more relaxed, I don't have the carcinoid breakthrough symptoms. Man, that first week of school when I got to teach 5 classes, really stressful. And of course, pandemic amplified everything. So I appreciate clarification of what the 5 words are that begin with E. And it's definitely in the purview of things that can lead to breakout symptoms.
Absolutely. And folks, I got to say too, like, this is one of my favorite things about the show is, you know, several people chimed in. There's really a community out here, and the big part of the value obviously is the information from our guests, but also the sharing of experiences and stories from the audience members and the community itself. And so they come to our aid often. Okay, so moving on with questions. Nalia says, if you have tumors in the small bowel, mesentery, and liver, are they considered NETs? And if your only symptom is slight flushing, grade 1, stage 4, do you still need to consider surgery?
So maybe I'll take it as a 2-part question, because there's a diagnosis and treatment. So can they be considered NETs? I think the diagnosis of the NETs is less about where the tumor started and where it spread to, but it's really my friendly neighborhood pathologist looking under the microscope. I really rely on them to say, this is a neuroendocrine tumor. Here's a subtype if it could be identified. And then there are key things I know a lot of listeners are really very savvy about. So there are markers called Ki-67. It might be referred to as mitotic index. There's another marker called MIB1. But all this is really geared towards getting more about granular detail, not just as an neuroendocrine tumor, but I as an oncologist need to know, is it well differentiated? Is it poorly differentiated, treated differently? It would help answer the question about surgery. But let's say, for example, a small bowel type of neuroendocrine tumor, let's say it's called well differentiated. And these index markers are stains that the pathologist looks at and they count. And then that helps us to determine under the microscope, are the cells dividing rapidly? Is it a really aggressive cancer expected to spread within the next few months without treatment? Or is it a more slow and growing tumor that might take months or even years to progress? But yeah, so if it's for example, a low-grade neuroendocrine tumor, relatively less aggressive, from the small bowel, if it's spread to the liver, then surgery would be done with intent to cure. If surgery is not done, there's no current other type of therapy, targeted or otherwise, that would be likely to eliminate, or whatever word we want to use, the C word of cure, or eliminate, get rid of the type of tumor without surgery. Surgery may be sufficient by itself. Surgery may be supplemented by other therapies soon after the surgery or months down the road with surveillance. So if your goal for a small bowel neuroendocrine tumor, to diagnose it correctly, your pathologist needs to work with your oncologist first. If it's a low-grade neuroendocrine tumor, then surgery would certainly be appropriate. Things are in the middle, may be appropriate, but that's how multidisciplinary teams are crucial. The surgeons who have expertise in NETs, with oncologists who understand NETs very well, with pathologists and others to really be able to talk about cases on an individual basis and make the best care plan in concert with the patient's goals of care.
Got it. Thank you. And thank you for your question, Nalia. We talked earlier in the show, folks, about the reach of this program and how I love to see that. So I just want to send a special shout out to Benta from Nigeria, who I've seen on the show before too. West Africa has a special place in my heart. Benta, so good to see you. I never made it to Nigeria, but I'm a big fan of Nigerian music. So I'm glad you're here. Nikki says, I had surgery 5 years ago and I've been told that I'm cured, but still have the symptoms, and they keep telling me it's IBS and it will clear up. This is a big one, a broad one, but I think this one's important. what are your thoughts here? What do you think she should do at this point?
Yeah. Just like, when I was mentioning multidisciplinary team, there are gastroenterologists who have special interest and expertise in the clinical care from a gastroenterology standpoint, things like this, but the bowel movements and whatnot, without knowing the exact type of tumor that was mentioned, I'll speculate maybe it's a bowel type of tumor. So if bowel is resected and taken out surgically, then definitely I tell people you have new plumbing, a new anatomy. So, and it won't take a few days or a few weeks after the surgery to get kind of an equilibration of feeling better in terms of bowel habits. It could take years. And then with the course of time, if a year passes or 2 years passes in surgery or more, like 5 years, and if there's a new normal established where maybe you're having 4 bowel movements a day, but before that you were only having 1 every other day, that might be the new normal. Will that necessarily indicate the cancer came back? Not necessarily. It could just be less footage, square footage or square metrics for non-Americans, in terms of the area, surface area of your bowels is less because you had surgery, less ability to absorb water and nutrients from food, and that may just be the state of affairs. Maybe there are medications that can help with that. If the implication is the scans don't show any evidence of recurrent malignancy, and the ultimate real question is there a cancer that someone's not catching? It's conceivable if there are even just a small amount of cells that aren't large enough to form masses seen on any kind of scan, and they're just not showing up. Maybe the test is insensitive enough. Are there cells releasing carcinoid type of hormones and causing that? It's possible, but certainly if a lot of bowel is taken out as part of the surgery, my guess would be that would be more likely to be the cause. And there are gastroenterologists who can help with that. The symptoms related to surgery, long-term consequences of that from bowel surgery.
Yeah. Thanks, Nikki. Hope that helped. And if you have a follow-up question, please let us know. Nancy, who was asking the question earlier about traveling 500 miles, says, I understand the need for a surgeon follow-up, but for how long will I need to see him in person specifically? If because she's doing well and she hasn't gotten an answer about that, how long is typical, I think is what she's trying to get to, because she's like, I get it, but I'm feeling good. Is this, forever? Is this for a year?
Sure. Yeah. Just maybe some clarification of how far out she's asking from surgery already. If it's a matter of weeks or months, I think at least one post-operative visit in person for the surgeon who did the surgery to examine. I say the surgeon who did the surgery very specifically because a positive you could find surgeons locally, but the surgeon, I think it's important for the surgeon who saw the insides and did the actual surgery. It's not just a matter of pride, but I think, again, safety. Does that need to be happening for many, many months and many, many years? Medically, very unusual for that to be the case. But usually the baton is fully passed back to the medical oncologist, who's really kind of the point guard, quarterback, whatever analogy, center in European football, I don't know how to say, who's really kind of in charge of the care. And if a surgeon is appropriate, re-referral back at that point in time is fine. So my ultimate answer is, I think at least one post-operative visit, if all is well. Probably the role of the surgeon in 6, 9, 12 months, years out wouldn't be playing a center role at all.
Sure, got you. So we've had a couple of questions, and we always do every week these days about the vaccine, about COVID-19 vaccine.
Yeah.
Some of them are about the booster shot. Some are still reluctant to get the vaccine due to their situation, their case. They're worried as a net patient. So I have a question that I hope captures all of them. The easy one is, should a net patient get the COVID vaccine? But I know it's a little more nuanced than that. So are there certain net patients experiencing certain things that should be more cautious or considerate of certain aspects of it? Is it just a blanket statement? How do you feel about that? That's every week we get questions about it.
Of course. Yeah, no, it's really, now we're basically more or less 10 months in, at least in the US, having access to the vaccine. It's widely available. It's for free. I'm a strong proponent of getting vaccinated against COVID-19, as I think the risk of getting the actual infection and the risk of short, long-term consequences far outweighs. If I put my hands apart like this is what I'm doing in terms of saying the risk of the actual COVID infection. Yeah, of course, just to be clear, the COVID vaccination does not prevent infection, but severely minimizes the extent of infection, duration of infection, and the ability to pass it on to others. So I think it's something that, first and foremost, patients with NETs and just globally cancer, unless there's an exception, I would say I really encourage you all to get the COVID-19 vaccination to protect yourselves, because you're going through, in some cases, very aggressive treatment, whether it's surgery, but even if not surgery, but all forms of treatment to try and attack a cancer that's plaguing you and maybe causing symptoms like pain or the hormonal symptoms. We have a vaccination, just we have influenza vaccinations, again, to minimize the chance that something like a severe infection like that would compromise your health. When in about last month, when the FDA was having Friday afternoon conversations, and then the answer was changing over a matter of days, they were talking about immunosuppressed populations. And so some examples would be patients with rheumatologic disorders or HIV as some examples. And then I got tons of emails like the Friday evening and into the Monday from patients saying, well, I'm immunosuppressed, I have cancer. And some are several years out from treatment, have no evidence of cancer, including NET patients, and others in the middle of active treatment. So I think in terms of priority and relative urgency, patients with cancer undergoing active therapy, I think can and should have immediate access to the booster. It's now becoming more widely available a month later. Patients who don't have any evidence of cancer, I still strongly recommend that they get it. The booster vaccination at this point, has been approved for the Pfizer, and for those who got the 2-version Moderna series, I know it's under very active discussion with FDA. I have no doubt that they're going to go through and approve it. And then Johnson & Johnson is still up in the air. Some recent studies from their consortia, is one called COVID and Cancer 19 Consortium, and they're widely available online and publishing great work, and really looking at this from a data-driven standpoint and saying, what type of cancer patients with cancer, are there any specific types of cancers or specific types of treatment that are really causing a more compromised immune system for which early vaccination is that much more urgent? Mm-hmm. And so definitely people with like lymphomas and leukemias and some types of cancer where they're getting immunosuppressive medications really at the top of the list. But I think globally we're learning more day by day, week by week. I never blanket anything and say one size fits all, but I think in this case, unless there's a medical reason that someone would get ill from vaccination, which is after millions of people have gotten vaccinated, really hard to find, I just globally recommend it to my patients.
Got it. Hope that helps everybody. And I know that's a question that you all have. So I hope that gives a little bit of clarity. So moving on, Jesse says, I'm on 120 milligrams every 19 days, and I still have breakthrough symptoms a few days before my injection. Mm-hmm. Would you shorten the time between the injections even more? Or would it be better to do 60 milligrams every 2 weeks, or is that an option? And let's also clarify for those who may be new to this, like what injection she's talking about.
Absolutely. Yeah, no, great question. And there's a lot of logistics at play. So then when I try to dissect that question, when I get that, is asking, and so just for everyone's edification, yes, referring to injections. So the hormones that come out are basically chemicals generated by the tumor, and they spill out into the bloodstream, and they're receptors. So if you ever had something called an octreotide scan, which is a little older news now, but dotatate scan or other types of PET scans that are specific to NETs, if they literally light up when we look at them, that means the cells in those tumors have receptors that the hormones bind to. And so these injections, so there's octreotide, there's one that's really short acting over a few hours, there's a monthly version every 28 days, and a cousin called lanreotide, so it's one or the other, not both. They block the receptors, and that's how it works. And not only can it slow down growth of the tumor potentially, but also try and prevent those symptoms from the hormones coming out. And what Jesse's referring to is standard use of this, whether it's someone newly diagnosed with a metastatic NET that has been shown to light up on these PET scans and other similar scans, that sometimes they don't work for the whole 28 days. And so questions that come to mind are is someone having breakthrough symptoms? Are the things that precipitate it? So now I know to refer to it as the 5 E's, but is it times of stress that are doing it? Some strategies for overcoming that are maybe I might prefer, for example, prescribing the short-acting octreotide that patients can self-administer at home. It's not too hard, but nurses in my clinic might typically teach how to inject in the belly and do different sites under the skin, subcutaneous, and inject it, and that helps to offer relief. If it's kind of an ongoing pattern a few months in a row that you're making 22 days, but not the 28th day before the injection, the physician may wish to increase the dose of the octreotide or the lanreotide, the monthly dosing, and that might help. And it's relatively safe to increase doses. Some types of cancer drugs, you really have to be careful and you get the tipping point of side effects. These are relatively safe. But something I think we've learned in recent years, the octreotide is intended to be injected into the muscle with a kind of a deep needle, the gluteus maximus, the butt muscle. The lanreotide is subcutaneous, but also in the butt. I think, and I don't have strong evidence to prove this, I don't think anyone's done a study yet, but I think sometimes we've seen in patients where if there's a challenge getting it injected, then my question is, the drug is right, the dose may be right, but not all of it was delivered effectively. Now I'm thinking really of the octreotide, the penetration of the needle into the muscle, maybe not all of it got there, and maybe that's why it's not working for the full 28 days. It's a question to ask. Sometimes what I do is someone is on the long-acting octreotide, hearing that story, maybe we might switch to lanreotide, which is a little bit, it's a different way to inject. It's not that's better or worse. It's a different drug, but a cousin drug. Maybe the delivery might need to be addressed, so just to make sure it's effectively delivered. So in addition to the dose, in addition to the drug, in addition to the mechanism of delivery, there are a few things to think of. In addition, there's another drug called telitristat that's been investigated the last few years. And sometimes if, gosh, this monthly dose just isn't working and the self-injection dose is not working or not really a good option, telitristat has really come out in the market and is an option.
Awesome. Thank you, Dr. Lewin. Thank you, Jesse, for all your great questions so far today. Next question from Susan. What are your feelings, or what is your feeling for the Y90 treatment? I have liver-only lesions, and I'm getting ready for my 5th round since 2015. It's been very effective, but I know its use is controversial. And my IR, which I'm assuming is interventional radiologist, is one of the best. So Y90 treatment.
Yeah, well, I'm glad to hear you're an expert hands. The growing field of interventional radiology, I respect them a lot. I tell people I don't do interventions. I'm not a surgeon or an interventional radiologist. I just talk about things. And this is a great topic. So I mean, your audience, just so you know, I'm not seeing the feed, but Rain is reading them out to me. You guys are really savvy. So kudos.
I told you.
Really savvy. So the Y90, so just giving a little context, yttrium-90, it's a radioactive isotope. So radioactive stuff is used in cancer, prostate cancer, seeds, beads, all kinds of different things. And what we call regional therapy approach. So in this case, I believe it's referring to neuroendocrine tumors that spread to the liver. And so arteries and veins are coming out. There are major large ones. And interventional radiology team members are becoming increasingly experts in how to access it and just pummel this with radioactive seeds that work not just for days, weeks, but even months down the road. One of my IR docs tells me, we do MRIs every few months after it, maybe 4 to 6 weeks after the first one, but you're not really going to be able to answer the question until as much as 9 months down the road, which is very profound. If I heard correctly, 4 or 5 treatments, that's amazing. I think the field of GI oncology and NETs, interdisciplinary, is really trying to figure this out. It's definitely on a case-by-case basis. Some of the concerns I have and others have is that the long-term potential effects of the Y90 on the liver health. And so if patients don't have cirrhosis is scarring in the liver, like the kidney, is a filter of our blood, of toxins to expel. That ability to filter, if it's scarred over by repeated radiation, could compromise that. So it's really definitely a case-by-case basis about, is the liver inflamed? Some blood tests can tell that. Sometimes you can tell in scans how the reaction is to previous. So it's not one size fits all. It's definitely appropriate to have interdisciplinary team members and the patient really discuss and goals of care. Certainly it's something where I describe it to patients. It's not something you can do infinitely number of times. It probably has a certain number of times before it can no longer be done safely. If you can get to 4 or 5 and it's done safely, that's amazing.
Thanks, Susan. I appreciate that. Great question. And yes, our audience is well educated for sure. Okay, next question from Skip. Skip says, my nets are stable, labs are normal, but my chromogranin A keeps inching up month by month. Why is this happening? And let's also say, what is the relevance of chromogranin A in this situation?
Yeah. Great question once again. And I'm glad we're getting into the space of biomarkers. So biomarkers are things, they're testable things that can maybe predict maybe the course of cancer. Is it progressing? Is it something like a tiebreaker for scans? Is it predictive of whether or not a treatment would work? So what we call predictive biomarkers. Chromogranin A has really become notorious, I'll tell you. If it's not something that's controversial in your mind, I'll tell you, among neuroendocrine tumor specialists, more and more, we're thinking of it as a controversial type of marker. Globally, in GI cancers, like pancreas cancer has something called CA19-9, colon cancer, carcinoid embryonic antigen. We talk about, I don't want to get all statistical here because I'm definitely not a biostatistician, positive predictive value or sensitivity and specificity, meaning if you have it, does it show up on the test? Does it not show up on the test? Whether it's NETs and chromogranin A, whether it's CEA and colorectal cancer, it's definitely not even valid in 100% of patients. It's more about half or a little more than half. Chromogranin A has become notorious because there are a lot of things that can falsely make it go up. So just one example, acid reflux medication, omeprazole is one example. If you take that, man, that can make a number falsely too high and cause a lot of patient and provider anxiety. Oh gosh, is the cancer progressing? So the gold standard still remains the imaging. I like to use markers tailored in a specific place, maybe as a tiebreaker if there's equivocal, meaning uncertain amount of progression or progression at all. Maybe it's an example that Lutathera, the PRRT treatment, or Y90 causes an immense flare of inflammation that at face value might be mistaken for growth of the cancer, but it's not, it's inflammation. The chromogranin A, as an example, might, and I emphasize might with asterisk and underlined, might be helpful as a tiebreaker. But I think increasingly, honestly, neuroendocrine tumor experts are thinking, should we do away with checking it? Because it just causes a lot more angst and not enough value. That's something definitely to be talked about, independent of whether or not someone has acid reflux. I tell patients for these type of markers that are non-specific, not even to cancer, let alone NETs, you can check at 8 a.m. and 8 p.m. and have a different value.
Wow. And
sometimes I'll have in the act about a year ago from at least the US, not just permitted, but empowered patients say results will be released immediately. Sometimes physicians like me we don't even have a chance to look at it yet, and patients will call in. It went up by a factor of 5, or like a minute by 5 points, but I'm saying, well, there's a range to it. It went up from like 5 to 10. I'm just really just using a regular example, but their normal range is up to 37. Then that was totally in the normal value. So I think it has more opportunity to create anxiety than have value to answer the question, is my NET under control, or did it come back, or any kind of cancer? So just know in general, and I've been having conversation with patients that saying, I don't think the chromogranin A is really helpful in you. It could cause more anxiety than not. I'm willing to stop checking it, but I want to check with you first. What do you think about that? Just understanding that's definitely not going to be the primary marker of answering a question when they meet with me after scans.
Gotcha. Hey, thanks, Skip. And everybody, great questions today. Another good one from Susan. What's your feeling on the alpha PRRT so far? I know that's something new. Let's talk about it. Let's get into it.
New toys, huh? So I was referring to earlier. So I'm a New Yorker. You might detect in my accent or the rapidity of my speech. But I trained at Morrison Kettering Cancer Center in my last 6 months. It was a great blessing. Dr. David Kellison is an international expert in GI oncology, and in about 2/3 of a day, we saw patients from different parts of the country with NETs, and I think all 3 were carcinoid that day. And he turned to me at the end of the clinic. Usually he would say, do you have any questions? I'll ask some questions and learn from his wisdom. He'd say, you saw 3 cases of carcinoid NETs today. You are now a world expert. And I kind of laughed. And I'm like, and he goes, no, I'm serious, because some oncologists might go their whole career and never see a single case. And now you saw 3. And at that time, the whole PRRT issue, I'm talking about Memorial Sloan Kettering Cancer Center, premier, first cancer hospital in America, in the world. We didn't have it at the time because it wasn't in America, and some patients of means were traveling to Brussels. Rumor was Australia had it, some German centers had it. And in the subsequent years, when I've been in Minnesota, I've heard of patients going to Switzerland and other centers of excellence. I think it was in Bern or elsewhere. And then when the NETTER study was done, led by researchers at Moffitt Cancer Center, and really brought the forefront, pushing for the FDA approval, I believe it was January 2018, it's totally opened up the game, because we had targeted agents that had gone through tried and true clinical trials. We had some chemotherapy regimens that were kind of being phased out, because not only because they were toxic, but not as efficient. But when PRRT came onto the scene, my gosh, it's great. I'll keep in mind that the type of the radioactive agent is different than the ones that were previously used 10, 15 years ago and common in Europe and other centers outside the US. So it's a different radioisotope, but the general strategy of saying nuclear medicine, and to be able to give it as early as second-line therapy. So someone's diagnosed, maybe they're on lanreotide or octreotide, get great success, but when there's progression, I don't have an obligation like some other cancers that I have to give a specific other chemotherapy, a specific other targeted therapy before using the PRRT. It's been great. So having this at our center almost 4 years running and having patients come here and going through the process has been great. I think we've had some great responses. Patients feel better, and that's the number one thing for me. Carcinoid syndrome, when a patient says, I don't have any of that anymore, I can go to the bathroom, I can go out of my house and feel okay about sitting in the movies, maybe pre-pandemic times, maybe again, or just going out and enjoying life as music to my ears. the next frontier that I think one of the next frontiers is, what do you do if the cancer grows again despite previous PRRT now 6 months, 12 months, 24 months ago? I think we're learning as a field in the US and elsewhere, what is the next great thing? Can you go back and do PRRT again? We don't have the answer yet, but I hope we have that in the coming year or years.
Yeah, and this is something that comes up a lot too, Dr. Liu, that just what you said, can we revisit PRRT, et cetera. So I think it's going to be an ongoing conversation for a while, but hopefully we'll get some answers on that soon. Susan also comes back with a question kind of from the other perspective, looking at symptoms versus therapy. Best advice on handling the ever-present fatigue. I know this is something that a lot of NET patients deal with. And I don't know from your experience if you have anything that you'd like to weigh in on that, but thoughts on that?
Yeah. Is it specifically related to PRRT related fatigue, or just fatigue in general?
I think just the ever-present fatigue, probably from treatment, but also just I think from the disease. It might be referring to, because it was right after her question, but I think it may extend beyond that. My hunch.
Sure. I'll complement that with another common question: what's the best food or nutrients or vitamins to eat? I'll say I think exercise is the best thing to overcome fatigue. Sometimes we get in this cycle where the cancer itself as a root cause of fatigue, and fatigue makes you want to rest, but then the conditioning, lean body mass, becomes less. And so I won't say that a supplement or a specific vitamin or food is going to be the end all and be all, but really maintaining conditioning. I've had patients with stage 4 NETs and other types of cancers that are really aggressive, do marathons and ultrathons, and I'll tell you, or cross body fit and amazing things. And I'm not saying that's necessary. On occasion, I've done those things in my life, but even I don't do all those things. But walking is a great exercise. Walking is a great nutrient for your body. Walking is a great thing to do for improving your conditioning to help overcome fatigue. So it's that hump to get over is a challenge about how to do that. I tell patients that, for example, if you're having carcinoid syndrome and your answer might be, well, I have diarrhea, I can't escape my house, then stay local in your neighborhood. I've told even whether older patients or patients that at that point in their life can't get around as much and ambulate, you can walk circles around your house. That way you're always equal distance from your house and close to the bathroom if you need it. If you're in a park, take a bench, places where there are benches, you can sit down at intervals. But I think exercise is really the best thing. In that 5 E's with the type of foods, you may want to, my caveat there is maybe restrict some of those foods, but the fatigue, hydration is also a big thing. Just in general in life, and also cancer patients are always kind of, I feel, dehydrated. If you feel dehydrated, you're beyond dehydrated. So sometimes our mechanism is we definitely don't drink enough water in society. We're on the rush. More people have water bottles. There's no specific type of pH, and that's come up with a NET patient of mine recently, or alkaline water, or basic types of brands of water you get filtered water. Just it's a principle of hydrating as much as you can. I'm not one to tell people no coffee, but hydration is really key.
Well, what my approach to coffee is, like two glasses of water for each cup of coffee, yes, if I can, right? So I start my day with the water to go ahead and prehydrate before I dehydrate.
Exactly.
I just made that up, by the way.
I'm going to take it. Yeah.
Yeah, but folks, I am not a medical expert, but I have spent many years in the fitness industry. And I will just say, because I know exercise means a lot of different things, and some people are resistant to that because they think it means that marathon that Dr. Liu was referring to, or CrossFit or something like that. Is all it means, in terms of my opinion. You can disagree if you do, Dr. Liu, is getting your heart rate up.
Exactly.
So that could be a walk around the neighborhood. And if that is challenging for you, can also be isometric exercises, just holding yourself in a plank position, things like that, wall sit, easy body weight stuff. That was my background with body weight exercises. So anything that kind of gets you breathing a little more and your heart rate up is helpful. Absolutely. Okay. Lots of questions and about 11 minutes left. So we're going to keep moving forward. Karen, who is a friend of the foundation. Hey, Karen, I recently stopped my lanreotide because of side effects. What would my next option be? And just for a little bit of info, she's stage 4, grade 2, primary small ileum, too many to count in the liver, 1 on the spine and 3 on the stomach wall. So next options for stopping lanreotide because of the side effects.
Sure. Yeah, maybe if there's opportunity to clarify what the symptoms were, because in general, it's well tolerated, but I have no doubt, Nick, if it's breakthrough symptoms of the carcinoid type of syndrome versus others, or just not even on the injection, there might be opportunity to go forward with the PRRT treatment. That's discussion with the oncologist, and without getting into the kind of the financial aspects of things with insurance coverage, there might be an opportunity to state it as, the FDA approval and the current medical approval package constitutes progression of disease and on lanreotide or octreotide, but in some cases where it is not well tolerated, might be an opportunity to consider going forward with the PRRT. If for whatever reason it's not cleared, or it's not a preferred option of the patient or provider, or either way, other targeted therapies may be appropriate, or oral ones, as Afinitor, everolimus, as an example, Sutent, which is sunitinib. They're most well studied, especially in the pancreatic version of neuroendocrine tumors, but can be also used in other types of neuroendocrine tumors as well that are metastatic. Since I particularly heard that some of the site where the cancer went includes the spine, you definitely, that might actually provide an impetus to say maybe PRRT now, because that's something where, based on the location, or even if it's small in size, it's such a sensitive area that you're looking and playing chess, not just for now, but down the road, for that never to create a sizable enough tumor to compromise someone's ability to walk or to have feeling because of the area in the spine. So that might be an added reason to at least consider and discuss PRRT with your oncologist and team.
Got it. Sharon says, how much sandostatin is safe to be injected? My husband with renal problems is up to 60 milliliters every 28 days. Are there more side effects with strength?
Generally not. Generally, it's pretty well tolerated. I think you have to, negotiate and discuss it with the oncologist. I heard milliliters, which from the patient perspective, you get the vial and, and they receive the vial and, it gets cloudy, gets mixed up in the clinic and injected. But I generally think of it in milligrams and micrograms for the different, types of somatostatin analogs, lanreotide and octreotide. If it was meant as 60 milligrams, that's something that might be, higher. But in general, it's something that can be very well tolerated, higher doses. It's generally not restricted. If someone has kidney or liver issues, definitely need to discuss with the oncology team. And a lot of teams like mine, we have expert pharmacists who are cancer specific, and we consult with them and say, okay, if there's this particular set of lab values indicating some challenges of liver or kidney function, we just want to make sure to do this safely. A lot of times it can be done safely. But I think the answer is really ask your doctor and team.
Yeah, absolutely. All right, folks, we have just a little more than 5 minutes left. Great questions again, and plenty more. So we're keeping moving forward. This goes back to a question that we were touching on earlier. Ruth says, well, what test are you really suggesting then? Are you suggesting that the imaging, are you suggesting the imaging is the most important?
It depends on what, and my answer is yes. Imaging is most important so the current definition is this, and I'll say it's limited here, even though we're in the 21st century with all of those great testing modalities. A patient is a three-dimensional being, right? And a four-dimensional being. You can argue the tumor is also three-dimensional, but yet whether it's an MRI to look at your liver, maybe spread or other parts of the abdomen, a dotatate PET scan, all these are viewed in two-dimensional slices, right? And so we're looking at two-dimensional slices of a three-dimensional being of the tumor and the patient. So I'm always mindful of that. But at the end of the day, the current standards to say yes or no, is a treatment working, if we're talking about treatment, is looking at, is there a certain amount of progression? And usually it's like 20% or more, and also trying to interpret it, make sure there's no inflammation. It's not going to come, that answer is not going to come from a blood test, chromogranin A or otherwise currently. Neuroendocrine tumors, it's an opportunity to talk about genomics too. And molecular oncology is really at the forefront and standard and necessary for the predominant form of lung cancer called non-small cell lung cancer, other types of GI cancers. And that field is evolving, and I hope will evolve a lot. And I'm doing research, and many other people doing research in that field for NETs very specifically, to see how can we tailor molecular testing to help answer the question, can that be a nice and validated supplement to imaging? But right now, whether it's for diagnosis, and you want to determine the stage of a tumor that's been biopsied, and you want to determine the stage, imaging. And now it's a dotatate scan because it has better resolution than octreotide scan. Not every center has a dotatate scan, so sometimes a referral is necessary. But it's definitely helpful for getting to the point of PRRT or even the Y90 embolization of liver. Having a higher resolution scan can be helpful. For Y90, certainly MRI is useful as well. But in the end, if someone has surgery and there's no evidence of cancer, interval MRI abdomen, for example, is a standard, and I get that. the imaging is the key to answer the question, is the cancer back or not? Is a treatment working or not?
Got it. Thanks for your question. Next question from Fred. This is back to PRRT. Dr. Liu, I've heard and I've read different opinions on how long PRRT works after treatment. So how long does Lutathera actively work after someone has received that treatment?
Yeah, and a great question. I'm always struck by, I mentioned earlier in the broadcast, my interventional radiology colleague was talking about Y90 and saying, hey, this stuff can work for 9 months. Or you may not even find like best answer to your question, did this work, doc? Although usually in the field, a Y90 embolization could be done in the liver, and a month later we're getting a scan, and 3 months later, we're doing it. But I think with that knowledge that maybe 9 months later, if someone gets radiation for any type of cancer, I always tell patients, it doesn't just work on the days you showed up. It'll be working weeks and months down the road. It's just, that's the way radiation works biologically. And PRRT, I think of the same thing. I think there's a nice break of that 8-week period, and it was built into the initial studies, I think for good reason. There's a series of 4. I don't think it stops working after the 4th one is completed. I think borne out by the patients I've seen in the literature, I think there's, as a nuclear medicine radioactive type of treatment like the others, I think it's working for months, if not years. And it's one of those things that you'll only know when it's not working, and a scan will tell you there are new masses that weren't there before, or substantial growth of something that was treated. So it's kind of like you find out when it's not working, but you don't necessarily know, is it still working? There's no indication to go in and do biopsies unless it's on a clinical trial to answer the question 3 months later, biologically, what does it look like? But if it's doing its job effectively, ideally, there'll be a lot of death of the cells inside the tumors, dead tissue rather than actual active cancer cells. And that's the goal of therapy.
Got it. So Jim has a question back to, we had mentioned injections in the glutes, in the buttocks. Jim says 2 years in with lanreotide injections and multiple marble-like lumps in both buttocks that do not seem to be clearing up as they did early. Is there any effective method for clearing these up? And if not, what options are there if and when we run out of an injectable area in the buttocks?
That's a sign of long-term success in that you've gotten that many, presumably without progression of the cancer, which is great. Okay. But at the same time, one of the costs is you want to sit down comfortably. So these areas of injection that bunch up are scar tissue, sometimes things called lipomas or fatty involvement, or just scar tissue that builds up. It can be uncomfortable. But you're right. The goal is always to rotate in different sites. But at some point, if you're running out of sites, it's not I don't think a magic thing to do it just in the butt region, but it's somewhere where it's done because there's in everyone, whether we're trim and slim or otherwise, we have enough body fat there that there's you do it subcutaneously. If you're in a good enough position to have gotten enough, but still need to continue, there might be other sites where they're on the hip or belly. I mean, it's something that ultimately, if that's just what needs to be done, you talk to the doctor about potentially rotating to other sites.
Got it. So a couple of people are saying, Lisa says, thank you for taking the time to do this amazing information. Joy says, this has been a long awaited luncheon, plus having rain back. Thanks, Joy. Everybody is very appreciative of the information today. Great info today, Ruby says. So my final question, Dr. Liu, is, well, I just want to make sure, because I know you have a unique background and perspective with this disease. Is there anything that we didn't touch on today that you think is important for patients, whether new to this journey or long with it? Are there any, we talked about alpha therapy, or is there any new treatments that are coming down the pike that you're excited about? Anything that you feel like we have left untouched that you think is important from your background?
Yeah. I think I alluded to the word frontiers, so maybe I'll close out by the overarching word of hope. And this kind of really heterogeneous type of cancers compared to other type of really vicious cancers that I take over that patients have. I think there's great hope that the prognosis can be really good. And I have patients who are working 10 years later and just going about their lives and working, and they have metastatic neuroendocrine tumors and are really doing well. So I think hope is really key. There's more hope on the way in the form of treatments. I think things that will be unraveled in the years to come are the PRRT. What happens when the cancer grows again? Can we go back to it? There's an under 10% risk, but it's not zero risk of other types of cancers called secondary cancers like leukemia because of the impact of the PRRT on the bone marrow. So it's not a trivial thing to consider when studies are done to determine whether or not risk versus benefits are worth going back again, to be determined. The role of genomics, many of us are trying to look at that and see if that's the next frontier. To exactly answer your question, Rain, are there other targeted agents that are left on the table? if we do genomic profiles of each individual patient's tumor, that uncovers targets that are specific to that patient's tumor, that there are drugs on the market or as available on clinical trials to test, and specifically in patients with NETs. So yeah, no, I think I want to end for sure in saying a huge thank you to you and everyone from CCF. I love to interact with patient advocacy groups on social media. My handle is CancerAssassin1 on Twitter, Instagram, and others.
Love that, by the way.
Love to interact. Thanks. The whole purpose of it, when I came up with it 7 or 8 years ago, was really I'm thinking of I want to hone in and spare the human patient of unnecessary side effects. Mm-hmm. And the goal in trying to come up with new drug therapies and strategies is get after the cancer, but make the patient feel better. And that's what we're trying to do. And doing things like here today, patient education is a huge part of that. So thank you.
So folks, you heard that Cancer Assassin 1 on Twitter. That is Dr. Lou. Dr. Lou, we appreciate you being here as well. Thank you so much for spending time with us. And thank you all at home. As always, we hope this program helped answer some of your questions. And again, please reach out to CCF or at carcinoid.org, or you can message them here on their Facebook page if there's further information or further questions that you have. And always, thanks again to our presenting sponsor, Tercera Therapeutics. Without them, this program would not be possible. And finally, my name is Rain Bennett. I have been your host. Thank you for watching. And please join us next time on Luncheon with the Experts. And please hold close those that you love. Stay healthy. Stay safe, everybody. Bye-bye.
Thanks so much.